Aplastic anemia is an hematologic disease. Look at this picture, shows that normal bone marrow and blood production, and aplastic anemia bone marrow and blood cells. Look at this. Bone marrow biopsy for diagnosis. A detail going on. Introduction. Aplastic anemia is a rare but serious condition in which the bone marrow fails to produce enough blood cells. This failure can lead to pancytopenia and deficiency in all type of blood cells, red cells, white cells and platelets. Without adequate blood cell production, patients are at risk of severe infection, bleeding and other complications. Aplastic anemia can be congenital or acquired and various in severity, requiring prompt diagnosis and appropriate management to improve patients' outcomes. A definition. Aplastic anemia is defined as a rare blood disorder where bone marrow fails to produce enough blood cells, leading to fatigue, infections and bleeding tendencies. It can be caused by factors like autoimmune conditions, certain medications or exposure to toxic chemicals. Types. Congenital aplastic anemia. 1. Fanconic anemia, a rare genetic disorder causing marrow failure, typically appearing in childhood. 2. Dyskeratosis congenita, a genetic disorder characterized by premature aging, an increased risk of bone marrow failure. Acquired aplastic anemia. 1. Idiopathic aplastic anemia. The cause is unknown but may involve autoimmune processes. 2. Secondary aplastic anemia caused by exposure to toxins, drugs, infections or radiation. Causes. 1. Idiopathic unknown causes. Approximately 70% of cases. 2. Radiation exposure. High doses of radiation, often from cancer treatment. 3. Toxic chemicals. Exposure to benzoin, pesticides, and other toxic substances. 4. Medications. Certain drugs such as chloramphenicol, non-steroidal anti-inflammatory drugs, and anti-seizures medications. 5. Viral infections. Epstein-Barr virus (EBV), hepatitis virus, and human immunodeficiency virus (HIV). 6. Autoimmune disorders, conditions where the immune system mistakenly attacks bone marrow cells. Risk factors. 1. Family history. Genetic predisposition, especially for Fanconi anemia. 2. Previous radiation or chemotherapy, especially relevant in cancer patients. 5. Exposure to toxins, industrial and agricultural chemicals. 4. Viral infections, hepatitis, EBV, HIV, etc. 5. Medications. Prolonged or heavy use of certain medications linked to bone marrow suppressants. Complications. 1. Severe infections due to low white blood cell count, neutropenia. 2. Excessive bleeding resulting from low platelet count. 3. Anemia related to fatigue from low red blood cell levels. 4. Increased risk of acute myeloid leukemia. Rare progression to leukemia. 5. Heart problems due to chronic anemia. The heart may need to work harder, leading to conditions such as heart failure. Pathophysiology. Aplastic anemia arises from the destruction or impairment of hematopoietic stem cells in the bone marrow, which are responsible for generating all blood cells. In acquired forms, this may result from immune mediated damage by a T cells attack the bone marrow. For congenital types, genetic mutations disrupt cell proliferation or repair mechanisms, leading to ineffective marrow production Here is step-by-step breakdown of the pathophysiology of aplastic anemia. Step 1. Initial trigger or genetic mutation. Step 2. Immune-mediated attack on bone marrow. Step 3. Cytokine release and bone marrow suppression. Step 4. Decreased hematopoiesis, blood cell production. Step 5. Pancytopenia means low counts of all blood cell types. Red blood cells, white blood cells, particularly neutrophils and platelets. Step 6. Clinical manifestations and complications. Neutropenia leads to an increased susceptibility to infections. Thrombocytopenia causes bleeding tendencies. Risk for internal bleeding. Step 7. Secondary complications. Severe aplastic anemia can lead to life-threatening infections, uncontrollable bleeding, and complications such as acute myeloid leukemia or myelodysplastic syndromes in some cases. This step-by-step process illustrates how aplastic anemia develops from an initial trigger, immune or genetic, to the systemic impact seen in clinical symptoms and potential complications. Signs and symptoms. 1. Fatigue and weakness due to anemia. 2. Pallor, a pale skin tone resulting from decreased hemoglobin. 3. Frequent infections due to reduced white blood cells. 4. Easy brushing and bleeding, such as nosebleeds or gum bleeding from low platelet counts. 5. Shortness of breath, especially during physical activity. 6. Dizziness or lightheadedness due to decreased oxygenation. Diagnosis. 1. Complete blood count CBC revolves pancytopenia. 2. Bone marrow biopsy, essential for confirming the diagnosis, showing hypocellularity. 3. Flow cytometry and cytogenetic testing to distinguish between aplastic anemia and other hematological disorders. 4. Liver function and viral panels to rule out infections or other systemic causes. 5. Genetic testing to identify congenital causes in younger patients. Nursing diagnosis. 1. Risk for infection related to reduced leukocyte count. 2. Risk for bleeding related to thrombocytopenia. 3. Activity intolerance related to anemia and fatigue. 4. Impaired tissue perfusion and related to low hemoglobin levels. 5. Anxiety related to illness, diagnosis and uncertainty of outcome. Management, medical management. 1. Blood transfusion to manage anemia and thrombocytopenia. 2. Immunosuppressive therapy, drugs like anti-thymocyte globulin ATG and cyclosporin to suppress immune attack on marrow. 3. Stem cell transplantation in severe cases, often curative in younger patients with a matched donor. 4. Growth factors such as G, CSF or erythropoietin stimulate blood cell production. Nursing management. 1. Infection prevention, hand hygiene, protective isolation if neutropenic. 2. Bleeding precautions, avoiding invasive procedures, using soft toothbrushes and closely monitoring platelet counts. 3. Energy conservation, encouraging rest and pacing activities. 4. Emotional support, counseling involving family and supporting coping strategies. 5. Patient education about symptoms to watch for, avoiding exposure to infections and adhering to medication regimes. Treatments. 1. Immunosuppressive therapy for acquired aplastic anemia. 2. Bone marrow transplant preferred in younger patients with a matched sibling donor. 3. Androgens occasionally used to stimulate blood production in specific cases. 4. Antibiotics and antivirals for treating infections or prophylaxis. Psychosocial medicine. 1. Emotional support. Diagnosis of a life-threatening illness can cause significant stress. Counseling and support groups can provide relief. 2. Social support. Patients may need assistance with daily tasks or may face isolation due to infection precautions. 3. Financial impact. Treatment is expensive, especially with transplants and ongoing medications necessitating financial planning and possibly social work involvement. Prevention. While aplastic anemia cannot always be prevented, the risk of acquired forms can be minimized by 1. Avoiding toxins, reducing exposure to chemicals and radiation. 2. Viral infection prevention, proper vaccination and precautions against blood-borne infections. 3. Cautious medication use, avoiding unnecessary use of drugs known to affect the bone marrow. In conclusion, aplastic anemia is a severe hematologic disorder requiring immediate and comprehensive management to improve quality of life and survival. Advances in immunosuppressive therapy and stem cell transplantation have significantly improved prognosis, particularly in younger patients. With proper treatment and suppressive care, many patients achieve remission or manage the disease effectively. Thank you. Have a nice day.